Hello, so today we'll be doing Pediatrics OSCE exam 1. This will be our first Pediatric OSCE exam tutorial. So make sure you subscribe, like, and comment, and share this video to the person who will soon begin to write the exam or who are writing their exams. So we are going to go through basically about 10 stations. So let's start. So this is station 1, and it's saying, so this is station 1. So the picture below is of a 12-year-old boy who had a history of respiratory illness 6 weeks ago. He has now developed involuntary movements of upper and lower limbs, and you can see the movement of the lower limbs as if the person is dancing. So the first question is, what is the most likely diagnosis? Then question 2, what investigations will you do? Question 3, give 2 differentials. Then question 4, what are the risk factors for this condition? Then question 5, how will you manage this patient? So the history is the one which is going to give you the diagnosis. So you have to note of the age. The boy is 12 years old. He has a respiratory illness 6 weeks ago. 2, then the movement itself. So here, the most likely diagnosis is acute rheumatic fever. So it's not this, but this feature is hidden scoria, but it's not the most likely diagnosis because the child, from what the child has displayed, he had respiratory illness, so that's typical for acute rheumatic fever, and the St. Vitus dance or hidden scoria is one of the major criteria for diagnosis of acute rheumatic fever. So that's the most likely diagnosis. So let's move on to question 2. So what investigations? So investigations, I think I put a bunch, so you can just choose any. So investigation, we have throat swab. So when you do a throat swab, so make sure you don't forget your throat culture for group A beta hemolytic streptococcus, of course, even sensitivity otherwise. Then you can also do a rapid streptococcal antigen test. Can do blood for MCS, can do anti-DNase beta or anti-DNase B test. Then can also do a C-reactive protein, and the C-reactive protein will be elevated. The ESR will also be high, which is a erythrocyte sedimentation rate. Then ASO or other streptococcal antibody titer will be elevated, which is anti-streptolysin or titers will also be elevated. That's the ASO, anti-streptolysin or then use titers. So they will also be elevated. FBC/DC, I'm sure you know, and they may be anemia, which means there will be other things such as leukocytosis as well. Then ECG, you have to use ECG to rule out rheumatic heart disease, and also so you have to note for prolonged PRI interval, and also you can do an echocardiograph. Then give 2 differentials for this. So differentials, we have Huntington's chorea, Wilson's disease, STRE, systemic lupus erythematosus. You can also have cerebral palsy, but should be last part, because you have to start with the most likely then the least likely. So this is the least likely. Then we have tics, we have hyperactivity. Then what are the risk factors for this condition? So the risk factors, like if you are paying attention, I was pointing out some of the risk factors such as age. I pointed it out. Okay, but let's start with the first ones. So we have first ones, low socioeconomic status. We also have overcrowding. We have age. So age, it happens in children who are 5 to 15 years old. Then also have unhygienic living conditions, previous history of rheumatic fever, and also prematurity is one of the risk factors. And question 5, how will you manage this patient? So management of these patients, we are going to talk of, and so this is going to help you remember everything, but I'll give you some pointers to put, since it's a tutorial and there's a time limit. So let's just go through everything. Then we are going to point out the most likely things you can put. So make sure there's bed rest and close monitoring for evidence of carditis. Have to reduce physical and emotional stress and use protective measures as indicated. Also, you have to use benzothine penicillin IM start. Then after IM, you have to put them on. You have to do it every 28 days for secondary prophylaxis. Then you get your anti-inflammatory agents. Then, of course, this is a point to tell you that anti-inflammatory agents such as prednisolone, aspirin, ibuprofen are not indicated here. So this is hidden chorea. So if you want to use it, you have to use it in other condition, but not in hidden chorea. That's the point. So they are not indicated. So prednisolone, aspirin, and the others, they are not indicated. So what do you use for severe chorea? So for severe chorea, you can use any of the following drugs. So you can use carbamazepine. So you can use carbamazepine. Can pay attention to to the dosages, but you have to use the dosages per local guidelines or at the ones indicated at the hospital facility. So these are some of the dosages, but make sure to check your facility for the exact ones. So we have 7 to 20 milligrams per kg per day. So 7 to 10 milligrams per kg per day usually is sufficient. Then you have to give it TDS per oral until chorea is controlled for at least 2 weeks. Then try off medication. Then the second one we can use is valproic acid, usually 15 to 20 milligrams per kg per day, can increase to 30 milligrams per kg per day, and given TDS per oral until chorea is controlled for at least 2 weeks. Then try off medication. Then the other is phenobarbital, 16 to 32 milligrams every 6 to 8 hours per oral, or alloperidol, 0.01 to 0.03 milligrams per kg per 24 hours, divided BID or BD, and chlorpromazine, 0.5 milligrams per kg every 4 to 6 hours per oral, can be used when the above are not available. So like I said, so these medications you have to get any of the following medications. So like we said, let's go through now the pointers how this condition will be managed. So point number one of take note of is you have to cause monitoring. Of course, you have to reduce physical and emotional stress. Benzene penicillin IM starts, then you do it every 28 days for prophylaxis, secondary prophylaxis. Then this, since this was just a pointer, so you don't have to indicate it when writing. So then the next point you're going to write is you can use any of the anticonvulsants or antipsychotic. So you can just pick any if you want. Yeah, I think we are done on this one. So this is some additional info. So for the causes of chorea, we have the pneumonic chorea itself. So C for chorea gravidarum, which is chorea which happens during pregnancy. Then we have Huntington's chorea. We have oral combined pills or oral contraceptive pills. Then we have rheumatic. So under rheumatic, that's where we have Schistosomiasis chorea. Then we also have endocrine for thyrotoxicosis. Then we have atherosclerotic chorea. Then that's all for this uh, station. Then station 2, this is the chest X-ray. Below is of a 6-year-old person who presented with difficulties in breathing for 3 days. Then on examination, he has a pulse of 140 beats per minute and the respiratory rate of 35 beats per minute and breath per minute, sorry, and a temperature of 38 degrees Celsius. His RVDR with a D4 count of 120 cells per deciliter. Then list 4 differential diagnoses. What is the most likely diagnosis? List 4 investigations you will order. Then list 2 likely complications. How will you manage this patient? So for the 4 differentials, so let's go through some risk factors. So this patient is 6 years old, presented with difficulties in breathing for 3 days. So this is the duration is 3 days. Then he has a pulse of this eye, it's eye. Then there is a respiratory rate, of course, 35 breaths per minute, eye temperature as well, and his RVDR CD4 count this row. For differentials, we have the first one is pneumocystic gyrovus pneumonia, immediate TB as the second one, and then we have histoplasmosis, cryptococcosis, coccidioidomycosis, sarcoidosis, blastomycosis, pulmonary TB, pneumonia, COVID-19 disease, actinomycosis. If I just guess the first 4, then we're all done. Then, what is the most likely diagnosis? So this is most likely pneumocystis, gyrovus pneumonia. That's the most likely diagnosis. Though it's similar with immediate TB, but it's not. You have to check through the history itself, how the patient has presented. So this is most likely pneumocystic gyrovus pneumonia, because that's how the risk factors are and how it commonly occurs in such patients. The investigations you can order, we have pulse oximetry, blood MCS, pulmonary function tests, your arterial blood gas, your ABG, your serum beta D glucan assays, your ESR and C-reactive protein, sputum specimens, which are usually obtained by induced sputum or bronchoscopy. And after you get them, then you do your methanamine silver or GEMSA or right GEMSA or modified Grocot or Weigat gram or monoclonal antibody stains. Then after that, other things you can do a viral since just did the CD4 count here. Then other things you can do a sputum MCS if you want, or you can just do your gene expert and the like to rule out TB. Then your full blood count is differential count, urine RAM, urine MCS, pleural fluid analysis. So you can do expert for MTB or rifampicin, biochemistry, cell count, and culture for the same pleural fluid you've gotten. Then CF analysis for MCS, gene expert, biochemistry, and others. Then also gastric ravage hospital must do for gene expert as well. But just make sure you get any of the 4 you can remember from this bunch of investigations. So likely complications. So there is 2 likely complications. We have respiratory failure and the pneumothorax. So these are not the only ones. So you can just pick any, or you can even add others which are going to make sense. But I just decided to go with this, and you can just research for the other complications for PCP. And how will you manage this patient? So this patient is in respiratory distress, so of course auto therapy is going to be indicated. Then they have high temperature, so an antipyretic, for example paracetamol, so but you can also of course use others. Then you have medication for PCP, which is Septrin or trimethoprim sulfamethoxazole. Then you can also use a corticosteroid. If you want, you can even put the exact corticosteroid you can use, like we did on antipyretic. We gave one example. So instead corticosteroid, e.g. this one. That's what you can do. Then of course this patient is all, they said you for them to have this CD4 count, so you can also switch IRT to other lines. Probably if they were on the first line, you can go to the second one, because this is most likely a failure of the first line, though we are not sure here. So you can just switch to other lines, fine, since we are not sure if they are on first or second line. Otherwise we are done on this station. So station 3, A 13-year-old boy presents to OPD with 1 week history of passing blood in urine for 1 week. He also complains of lower abdominal pain. He has a history of skin rash as well. Then, as a medical officer on call, you order, sorry, it's supposed to be you order urine for for microscopy. Then the picture below shows what the lab technician saw. So question 1, describe what you see. What is the most likely diagnosis? What feature will you see on abdominal ultrasound? Then list 4 complications of this condition. Question 5, how will you manage this patient? So describe what you see. So if you can see how the tail is looking and how its shape are, I'm sure you know the species for schistosoma. So you have to know which one looks like what, which one presents like what. So describe what you see. So there is a schistosome hematobium ova. So this specific ova is for hematobium. So schistosome hematobium ova. That's what we are seeing. Then what's the most likely diagnosis? So hematobium causes urinary schistosomiasis. So of course we have to take note of the others which causes intestinal schistosomiasis. So make sure you go through the other species. Then what feature will you see on abdominal ultrasound? So on urinary schistosomiasis, ultrasound views hydronephrosis, hydroretas, and bladder or irregularities may be visible as well. So also we have to differentiate the one for intestinal schistosomiasis, how it looks on abdominal ultrasound, because they all differ. And if I'm not mistaken, the one for intestinal schistosomiasis views on ultrasound, it views periportal fibrosis, if I'm not mistaken. But you have to take note of that as well, how they differ. Then complications of this condition. So this is urinary schistosomiasis. So of course we can have obstructive uropathy, hydronephrosis, chronic kidney disease, recurrent urinary infection, squamous cell carcinoma of the bladder. So I think we've mentioned some of the complications. Then how will you manage? So management here, you can do Prasquanta 40 milligrams per kg single dose, or you can actually divide this 40 milligrams into 2 oral doses. So you can do 2 oral doses of 20 milligrams per kg. Then of course an analgesia for the lower abdominal pain, since we are managing the patient, how the patient has presented. Then we are done with this station. Go to the next one. She's saying a 6-month infant presents to emergency room with a 1-day history of a backing cough, which was preceded by history of running nose. There is no history of fever, but history of difficulties in breathing. So what is the most likely diagnosis? List 2 causative organism. List 1 bedside exam you will order, or what will be your approach to the management of this patient? So a 6-month-old backing cough and runny nose. So this is the most likely group, or laryngotracheobronchitis. So if you can remember this big word, you can even put that too. You can say group, it's fine. Then these 2 causative organisms. So the first 2 are the most likely. So we have the first one, which is parainfluenza virus. So we can have type 1, 2. This is probably maybe supposed to be 3 and 4. Then we have respiratory syncytial virus. Then we have adenovirus, rhinovirus, enteroviruses, measles, metapneumovirus, influenza type A and type B. Then we have mycoplasma pneumonia, which is very rare, but you can just pick 2 from this. Then this 1 bedside investigation you order. So the bedside investigation you can order is a pulse oximetry. Then what will be your approach to the management of this patient? So since we are going to go through everything, so after we've managed, I'm going to give you pointers. In since this is an OSCE station, there are things you have to just take note of. So that will be your approach to the management of this patient. So of course you have to keep the child on the mother's lap and handle gently. Then you assess the level of severity, you encourage hydration, ensure the child is kept as calm as possible because continuing crying increases oxygen demand and causes respiratory muscle fatigue. Then you can also do a single dose of oral dexamethasone 0.15 milligrams per kg body weight or dexamethasone 0.6 milligrams per kg per oral stat, maximum dose of 12 milligrams, or oral prednisolone 1 to 2 milligrams per kg body weight. Or you can just check with your facility guidelines. Then, if difficulties in breathing occur, nebulized adrenaline can be given to provide temporary relief of symptoms. But there's no sort of difficulties in breathing. That's why we are saying if difficulties in breathing occur, this is what we're supposed to do. Then oxygen therapy as required. Then humidified air or steam inhalation is not advised. It has now been definitely shown to be ineffective in croup and should not be given. And the last point is keep home. So in an OSCE setup, maybe you just have to write the highlighted points. So what pointers can give you 4 marks here? So in an OSCE station, you can't manage to write everything like you've written here. So you can maybe start with maybe say oxygen. You put the child on oxygen, then you nebulize the adrenaline since of course it might occur. So you include that as a pointer and nebulize the adrenaline. Then here you can just if you want you can just say corticosteroid, then EG dexamethasone, that's point number 3. Then of course we have point number 3. I think then the last point should be keep warm. Then you can just pick any of these if you can remember any of these pointers here, like keep warm and keep calm, keep the child calm. Maybe you get 4 marks, but otherwise this is the overall thing you're supposed to do and some of the pointers to what you are not supposed to do. Okay, so we are done. So station 5, the picture below is of a 4-day-old neonate who presented to NICU with history of body hotness, jaundice, and repeated convulsions. 1. Name the posturing shown. 2. How do you manage repeated convulsions in neonates? 3. List 2 most likely differential diagnoses. Then 4. The patient is noted to have persistent conjugated hyperbilirubinemia. Of the 2 differentials, what is the diagnosis? Then how do you manage the above diagnosis? So this posturing, as you can see, so the name of the posturing is called obstotonus. So that's obstotonus. Then how do you manage repeated convulsions in neonates? So in neonates, the initial treatment is with phenobarbital, should be considered. So first start with phenobarbital. Then if seizures persist, you of course you have to repeat phenobarbital again. And if seizures persist, then you go to phenytoin. So phenytoin should be used. So phenobarbital, phenytoin, then again phenytoin. But you can just write it as this is, since they of course I'm sure they know what you are talking about. Then the third thing you can do if this method, the first pointers fails, then you can, if seizures still persist, it may require IV benzodiazepine such as lorazepam or midazolam, or maybe when I was a student, one of the doctors was giving us this data, said that if after phenytoin, you have to go for a senior consultant. So you can even just include it like this because I'm sure they will know that. Okay, I'm sure he learned it from somewhere, which is also correct because if these 2 persist, then even you doing this is the right call. Yeah. So move on to question 3, which is saying these two are most likely differential diagnosis. So the first two are the most likely, then these are some of the things you should take note of. So we have connectors, which is bilirubin encephalopathy. We also have neonatal sepsis, or you remove neonatal sepsis and just put pediatric bacterial meningitis if you want. Then of course we have congenital throat infections, cerebral palsy, neonatal sepsis again. Okay, you can just put it here. Okay. Then question 4: the patient is noted to have persistent and conjugated hyperbilirubinemia. Then of the two differentials, that's the most likely diagnosis. So of these two, which one do you think can have a persistent and conjugated hyperbilirubinemia? Okay, so this is most likely connectors if we have such raise in hyperbilirubinemia. Okay, they now do manage the above diagnosis. So management of connectors. Management of connectors, we have the same thing, the exchange transfusion, also phototherapy. So most people will tell you to stop breastfeeding, but actually breastfeeding should be continued in the infant who is well enough to have enteral feeding. So if if using formulations, you can use formula that are containing prebiotics if they are available, because formula containing prebiotics are expensive and they are not usually found, especially in our setup. So just make sure the woman continues to breastfeed the child. Then of course you can do other consultations, but this is the management for connectors. Okay, so we are done with station 5. So station 6, start the picture below, and the question is that follows. So question 2, list 2 signs you are able to see. So any signs you are able to see here. What is the most likely diagnosis? List 4 causes of the above diagnosis. How will you manage this patient? So these 2 signs we are able to see. So for the signs, we have sun-setting eyes. So they are sun-setting eyes. You can also see dilated visible scalp veins. So these are some of the dilated visible scalp veins. Then you have your prominent head with the abnormal contour of the head. You have the bulging eye and inability of the baby to look upward with the head facing forward. But you can just stick with these two, because these ones maybe you might find them hard to remember, but these ones are even typical. These two. Okay. So what's the most likely diagnosis? So this is most likely hydrocephalus. Then causes of the above condition. So I haven't classified the causes, but you can check out how you classify the causes, because there are a lot of ways to classify the causes for hydrocephalus. So I've just listed them. So you have congenital aqueductal stenosis, Dandoka malformation, Arnold Chiari type 2 malformation. Also, we have intrahepatic infections such as toxoplasmosis, CMV, rubella, meningitis, and also meningitis. And as you can see, these causes, I listed the ones which are most likely in a child like this. Yeah. Then how you manage this patient? So management, we have medical and surgical. Then medical is usually for helping you. So management, you have daily medical, you have daily measurement of occipitofrontal circumference. Also, uh, then the medical part is the one for acetazolamide, 25 to 100 milligrams per kg per day, which is a carbonic anhydrase inhibitor. Then ventricular tapping through the anterior fontanelles if still open, or treat underlying cause if identified. So if it was meningitis, you then need to treat it. Of course, there will be less swelling, and the child will start getting better. Then we have surgical or the shunt. So we have a lot. So we have ventriculoperitoneal, ventriculoatria, ventricular osseous, ventricular spinal, ventricular pleural. Yeah, so these are some of the shunts you can use. You can just pick any. Okay. Then station 7. So below is an endoscopic picture of a 5-year-old who presented with diarrhea for 2 weeks. He has history of prolonged use of antibiotics, then usually prescribed at the local clinic. So he has prolonged use of antibiotics. So this is the point. Then what is the most likely diagnosis? What investigations will you order? What are the two drugs of choice in the management of this condition? List four causes of chronic diarrhea. So most likely diagnosis. So as you can see, the child had the prolonged use of antibiotics. So this is most likely pseudomembranous colitis. And then what investigations we order? So we can order 2 MCS since they have already done the endoscopy. So we can just order 2 MCS. Of course, there are other investigations we can order. Just put one which is most likely investigation I can order here. Then what are the two drugs of choice? We have metronidazole and vancomycin. And of course, there are others, but these are most likely drugs you can order, especially they have availability in our setup. So this is metronidazole and vancomycin. That are the two drugs of choice in the management of this condition. And then these four causes of chronic diarrhea. So we have uh, four causes of, okay, you can just pick any four of HIV, TB, celiac disease, ulcerative colitis, lactose intolerance, Crohn's disease, chemotherapy, microscopic colitis, small intestinal bacterial overgrowth, or SIBO. So we can just pick any four from these. They cause chronic diarrhea, especially the first four. You can just pick the first four. Then additional info for this one is that you have to know that it is caused by Clostridium or by typhus. Then other potential questions they ask you on this is complications of diarrhea, which include dehydration, hypovolemic shock, electrolyte imbalance or depression. Then you have hypoproteinemia, renal failure. Those are some of the additional info I wanted to add on this station. Okay, station 8. Oh, this is a scenario now. So for the scenario, saying Judith Mwamba is a female 3 years old, brought to the facility by a biological mother, and narrates that the child has been complaining of fever. Then the fever is of 37.8 degrees Celsius. Then there is also loss of appetite. There is also coughing for 3 weeks. Then there is weight loss from 13 kg to 9 kg in 4 weeks. Then of course there is also diarrhea for more than 2 weeks. Then the mother's HIV status is unknown. So when asked, is unknown when asked, and only recalls doing it on the first antenatal booking in first trimester for due to this pregnancy, which was negative when she did it. Then on examination, you discover that she has white patches on the tongue and mouth. Then question 1, what is the most likely diagnosis for Judith Mwamba? Then what investigations can you order on Judith? You discover that Judith is RBD reactive. What's the WHO stage? Then how would you manage Judith in relation to the diagnosis you have made in question A? So I'm sure it's supposed to be question 1 above, sorry. In question 1 above, and the HIV status that has been diagnosed. So what has been diagnosed? Then question 5, what CART regimen will you give according to the 2022 Zambia consolidated guidelines? So this, they wanted this for guidelines here. So you can just, if you're answering from other places, you can just put your guidelines as well here. So just imagine they're asking you according to your latest guidelines. But I think probably soon we are going to have our own 2022 guidelines, because they have even started teaching the 2022 guidelines. So for this question, we're just going to go ahead with the 2020 ones. Okay. So what's the most likely diagnosis for Judith? We go back to the answers now. So Judith, so there is fever, loss of appetite, coughing, weight loss, and diarrhea. So these are most typical for TB. Then the other thing is she has white patches on the tongue and mouth. Then for someone, this is most likely we are suspecting Judith for TB for HIV. So if they have white patches and on the mouth and we might suspect them for HIV, so they can most likely have uh, oral candidiasis. So the most likely diagnosis here you can go with pulmonary tuberculosis, or if you are not sure, you can just remove the P. You can just say tuberculosis, but I'll go for pulmonary tuberculosis with oral candidiasis in a known or suspected HIV patient, because it's most likely we are highly suspecting this patient to have HIV, but we can't confirm with the suspicion. So of course, that's why this question 3 is saying you discover now. Okay. So what investigations can we order? So this is where we are going to even order the diagnostic counseling and testing or the HIV test. So we can do sputum for gene expert, your DCT or HIV testing, chest X-ray, urine lamp, sputum for AFB, then of course our FBC, GC, 2MCS, also nucleic acid amplification test, then of course you have to do them when they are available, of course. Then these were the only ones I managed to write, but you can put any. Then the next question is saying you discover that Judith is RVD reactive. What's the WHO stage? So for someone with PTB, pulmonary tuberculosis, and oral candidiasis, all these are typical for WHO stage 3. So Judith is WHO stage 3. Then now we do manage Judith in relation to the diagnosis we made in question A. So this diagnosis and the HIV that has been diagnosed. Okay. So this is just the same question. Now we just going for the answers for question 4. So these are the answers. So you have to start your ATT immediately with your 4 fixed dose combined. So you can do an intensive phase for 2 months on rifampicin and isoniazid and ethambutol, and the continuation phase for 4 months on rifampicin, isoniazid, and rifampicin, isoniazid. So when you are writing, so I'll give you the pointers when I'm done. Then of course ATT, then you combined with antifungal agent, then should be confirmed by susceptibility testing. So you have to know which antifungal is the causative organism will be susceptible to. Then start your CART as soon as ATT is tolerated, and this usually happens within 2 to 3 weeks after the initiation of ATT. So regardless of CD4 count or WHO clinical staging. So when you're writing, most of the time symptoms, you can just write these in full. Your ATT, start ATT, your antifungal, then of course start CART, because here we are being asked to mention the exact CART regimen. Okay, so this is question 4. Then question 5, what CART regimen will you give according to this? So the preferred first line for someone with co-infection of TB and HIV, then we discover them at the same time. We do the age is 3 years and the kg is 9 kg. So taking those into consideration, then you have to give your ABC plus 3TC plus RAL, which is the abacavir, ramivudine, and raltegravir. Then you have, of course, you have to double the dose of raltegravir, or you can use ABC, 3TC, and AZT is Dovdin. Then you can also use AZT, 3TC, and EFV equivalence. So Dovdin, amivudine equivalence. Then that's all for this question. So this is according to the 2020 Zambia consolidated guidelines. Okay, we are done on this station. So station 9 saying this is a hemogram of a 10-year-old who presented with a 2 months history of fever, loss of appetite, generalized body weakness, and abdominal fullness. Then WBC of 165. So this is 165. They are 165, and this is supposed to be 10 probably 10 to the power 3. Then platelets is 167. Then MCV 86 cubed millimeters per cubed millimeters. Then MCH was 30.6. The HB was 7.9 grams per deciliter. Then the reticulocyte count was 9.57%. Then the MCHC was 36.3%. Then list the abnormalities in the hemogram. Then question 2, list 2 differential diagnoses. Then question 3, list 2 investigations you will do to confirm the diagnosis. Then question 4, how will this patient be managed? Then list the abnormalities in the hemogram. So let's start with the answers. So we have a very high WBC, which is 165. So there was once we were writing for abnormalities on the hemogram, and we were told to actually write the terminologies, like if it's leukocytosis, we have to write leukocytosis, not very high WBC. So depending on what you are told or what you are required to write, you can write the required ones. Don't just stick with this. So if you want, so very high WBC, we have a very low HB, which is 7.9. It is low. Then also we have a very high reticulocyte count. This one is very high. Then these 2 differential diagnoses. So we have acute leukemia, chronic leukemia, and also myelodysplastic syndrome as one of the differential diagnoses. Then these 2 investigations we order. You can do a peripheral smear, we can do a bone marrow aspirate and biopsy. So these are some of the 2 investigations we can order: peripheral smear and a bone marrow aspirate and biopsy. Then question 4, how you manage. So how will this patient be managed? So of course you encourage your hydration, your broad spectrum IV antibiotics, your plasmapheresis, your blood transfusion. Specifically, you can go for the red cell transfusion. And then of course allopurinol, you can give allopurinol to prevent hyperuricemia. Then after finding out what the exact causes, or you can start the patient on chemotherapy if indicated. So induction, then consolidation, then maintenance. So these are some of the phases you can go for when you start chemotherapy. Then we are done on this station. And then station 10, which is our last station. So below is a picture of a 14-year-old boy who presented to OPD. So list 2 possible causes of the presentation in our setting. So in our settings is Zambia worldwide. So list 4 investigations we order, and then what is the commonest hematological disorder among children in Zambia. Then list 4 renal complications of the above disorder. So list 2 possible causes. So in our setup, these are the most likely. So we can have severe malaria and sickle cell disease, because this patient has been treated with yellowing of the eyes, which is scleral jaundice. Then list 4 investigations we are going to order. So of course we can do our sequencing test and do our full blood count / differential count, peripheral blood smear, HB electrophoresis, and of course, since we included malaria here, so we can do URDT search, or specifically we can just do a parasite side. But yeah, but of course there are also others which we have not mentioned here, so don't be limited to these ones. Then what is the question 3? What is the commonest hematological disorder among children in Zambia? So the most likely hematological disorder is sickle cell disease. And then list 4 renal complications of the above disorder. So renal complications of the SCD, we have acute renal failure, chronic renal failure, nephrotic syndrome, hypertension, renal papillary necrosis, renal medullary carcinoma, chronic tuberointerstitial nephritis. You can also have asymptomatic hematuria. So these are some of the renal complications. Then we are done with the questions. Otherwise, thank you for watching, and if you haven't subscribed, make sure you subscribe, and also don't forget to hit the bell notification. All right.